Mhm. All right, good morning. It looks like we have people joining, so we will give everybody just a minute before we kick off.
Hey, I have one question, Elizabeth, real quick. Are we still going to be on all the time on video, or will you just be focusing on the person talking?
It's gonna run so everybody's on video for
All
the
the time. Okay.
Yeah. It looks like we have, well, the numbers are climbing. We have over 50 right now. So I'm gonna just give everybody another minute or two to log in and then we can get started. All right, is everyone ready? So welcome to today's town hall sponsored by AM Trace. We're really excited for your partnership. Today's town hall is titled Check Yourself. And I'd like to kick off by welcoming everybody to the session, let you know that this is being recorded and will be put into our on-demand library at the end. And I'd like to introduce today's moderator, which is Dr. Jody Hershey. Jody Hershey has over 35 years of work experience at the local, state, national public health levels, as well as in the private sector and corporate healthcare. He's a board certified in both family practice and preventive medicine and has an MPH in epidemiology from Johns Hopkins and a PhD in health promotion and education, curriculum and instruction from Virginia Tech. Dr. Hershey has held leadership positions and continues to serve on numerous committees for a variety of public and private board of directors, as well as local, regional, state, and national professional organizations, medical societies, health governance, and advisory boards. Since 2000, he served in leadership positions at NACCHO, including being president from 2003 to 2004. Dr. Hershey has taught in several academic and medical institutions at the undergraduate, graduate, and doctoral levels. He's received many awards on a local, state, and national level. Dr. Hershey's professional and academic interests, publications, and presentations include a diversity of public health and healthcare topics. Two of his special interests include health education, promotion, disease prevention, and medical advocacy. And I'd like to welcome Dr. Hershey.
Thank you, Elizabeth. I want to welcome all of you to the third day of NACCHO's Preparedness Summit. Today, I have the privilege of moderating this town hall entitled Check Yourself, that is being sponsored by AM Trace. I'm excited to hear presentations by Carla Kent and Allison Seidel from AM Trace, as well as Elizabeth Ruebush from ASTHO. Since the beginning of the COVID-19 pandemic response, many of us have had no options other than to react. With vaccination efforts finally underway, the time is now to evaluate our pandemic response efforts, including successes, failures, and challenges, as well as our standing policies, and prepare for tomorrow. How have we responded? What are the lessons learned? How do we track progress? How do we continue providing COVID-related services and return to providing our other health department services? How can we evaluate how ready our health departments are to continue doing everything that is being expected of us? We as public health professionals are in a very unique position right now. We have never had this much interest from the private sector and others in NACCHO and in local public health. This is our opportunity to take advantage of their interest and their expertise and to express our appreciation to them by participating in a live question and answer discussion following the presentations. So get ready to ask questions and to share your experiences. What's working, what's not working, as well as your challenges and your needs. I look forward to that discussion.
Wonderful, thank you, Dr. Hershey. So I'd like to now introduce the speakers from AM Trace, Allison Seidel and Carla Kent. Allison brings a wide range of public health and epidemiologic experience to the AM Trace team to assist in the response to the COVID-19 pandemic. For over 10 years, Allison has worked as an epidemiologist in several areas of public health, ranging from federal to state and to local public health. including the DoD Influenza Surveillance Program, where she monitored influenza and respiratory pathogens worldwide, the CDC Food Safety Centers of Excellence, improving surveillance and response to foodborne outbreaks at the local and state health departments, and Denver Public Health, understanding adverse events related to cannabis use, responding to outbreaks, and team lead for case investigations and contact tracing during the COVID-19 pandemic. She has a master's of public health and epidemiology from East Tennessee State University and is finishing up her doctor of public health and epidemiology at the Colorado School of Public Health. And also Ms. Kent. Ms. Kent is one of AM Trace's analysts with more than 10 years of data modeling, analysis, and visualization experience. Prior to joining the AM Trace team, she served as the advanced analytics lead at a consulting firm, delivering solutions for multiple industries with clients of all sizes, from small associations to multinational Fortune 500 companies. Ms. Kent is certified designer as well and is well versed in predictive and prescriptive statistical modeling and forecasting. She holds a BS in applied mathematics from the North Carolina State University. Welcome, ladies.
Thank you, Elizabeth. I will go ahead and get started. So Carla and I have a short presentation that we'll go through before we pass it off to the next Elizabeth. And we're just going to go through some of the work that we have done with AM Trace and looking at how we want to evaluate into the future as far as the COVID-19 response and how we see ourselves moving into the future. So you can go to the next slide. So there's three areas that we can think of. So there's obviously more than three areas, but three major areas that we look at when we're evaluating our response to the pandemic and understanding our readiness for the future. So the first one is the actual response to the pandemic. How well did local and state and territorial health departments do in responding to the pandemic? And that can help us find gaps to prepare for the next large scale public health event, or even to prepare ourselves for our public health departments as a whole. The second one that we can look at is the internal readiness that health departments were at when responding to this pandemic. When I was working at a local health department when the pandemic started, I think there was a lot of readiness, but I think there was definitely a lot of gaps, and there was some things that the pandemic brought that I don't think we expected, as far as the capacity of staffing that was needed when you're doing large scale public health contact tracing, the technology that was needed to do this contact tracing, and then additionally the staffing needs that were needed to do telework and looking at the kind of the burnout and the mental health of people working on the pandemic. And then the last area is the preparation for the future. So looking at as COVID kind of moves into the next phase, which is vaccinations, and it's becoming less of a response and more of just an additional duty that public health departments will be working on from here until very far into the future. And so how can health departments prepare themselves to be a public health department where COVID-19 is an equal partner with all of the other work that a public health department does? And what are some gaps and things that we need to be focusing on? So the health department response to COVID-19. So this is where we can look at the three kind of areas of the pandemic: testing, contact tracing, and case investigation, and vaccinations. And how can we combine all of this data? How can we combine all of these areas to see how well a health department did in responding to the COVID-19 pandemic? And stratifying this information by demographics, by geographic location. It can help us provide insight into the gaps that could be seen in this response, and also the positive things, the things that health departments did really well and responded to very quickly in order to get people tested and vaccinated and kind of quarantined and isolated. And then additionally, what policies were implemented to reduce the disease spread. So there's a website we'll show in a little bit that I think is a good kind of base of what we can do. So we at AM Trace, one of our clients, this is something we're starting to do with one of the clients that we work with, is looking at taking all of this information and all of this work we do with them, because we do these 3 areas with them: testing, vaccinations, and case investigations. How can we take all of this data? It's a huge wealth of data, huge wealth of knowledge. How can we take all that information, evaluate how well this health department did in responding to the pandemic, and then how does it recognize and kind of highlight gaps that they need to fill in order to work into the future in the next public health event, large scale event, or any event really, I guess. Go to the next slide, and I'll pass it off to Carla.
So this is just a really high level, simple example, I think, of how you can look at the data with cases, testing, and vaccinations. This is a single county, and it essentially just gives over time, over the last year, the number of cases as they've gone up and down, the testing that has been done in that same county. And then you can see when vaccinations began. And we'll show some, some more elaborate examples, I think, next. But this one, I think, is a pretty good, clear indicator of a very simple program that was started, vaccinations, and how it actually affected the cases in this particular county. So immediately when the vaccine program began, there was an immediate drop in cases. Now, obviously, some of that may be related to just human nature, but we have definitely seen, as we've gotten further along in the vaccine program, once we reached about 100,000 vaccinations per week, it has consistently been on the downward trend for the number of cases that we're seeing. Obviously, that also has affected our testing. One of the things that I think may not be extremely obvious in this particular slide, but you can see on the bottom with the vaccines there, I don't know, around early February, mid February, there was a drop in vaccinations because of I'm not even sure what the reason was, but there was a logistical error, I think, with getting all of them out to whatever this county was. And you can see almost exactly a week later, the testing numbers bumped up a little. So you can see how all of the things kind of work together, all the different activities and policies that are going on, how they all work together to affect the COVID itself. And so one of the things that we're doing is taking all of this data and putting it down at the immediately small local level down to the individual, the individual communities, to be able to establish how specific policies and activities and events that have happened, how they have affected those individual populations. And this is one of those examples. This particular website, I believe, was on a conference that we went to a couple of weeks ago. But this is a good example of how you can use modeling techniques and statistical data collection practices to be able to look at the individual actions and how they could predictively affect, for forecasting purposes. One of the big things that we do is help to be able to establish things like, what are your staffing needs going to be? What do we think is going to happen if we have these specific policies in place, or if we do these particular events and activities? How is it going to affect our numbers going forward? And one of the biggest problems that we had, obviously all of us did when we started this COVID pandemic, was we didn't really have data to work off of. The whole concept of predictive analytics is that you use the historical activities to be able to predict your future. And it's obviously very difficult to do if you have no historical data. So we have definitely been working from that lens from the beginning of this to make sure that we have collected as much data as we possibly can so that we can use that to figure out what are our next steps? What do we do now?
So that kind of really is a good segue into the kind of the next evaluation piece that we think of when working with counties and clients and trying to see how prepared were we to work on a pandemic. And I think one piece that we can evaluate using different evaluation models, logic models, things like that, is looking at the staffing capacity is the biggest one. I think that was something that I think a lot of health departments had to redeploy people into working on the COVID-19 pandemic, which is a part of a pandemic response. You know, you are naturally going to redeploy people within your health department to work on this response. But I think one of the things that many of us maybe didn't anticipate was just the massive number of people we needed for contact tracing. And so I think that is something that determining what it was at the time that we, the health department needed and how they filled that gap or how they filled that capacity need. Looking at the telework options and how quickly a health department was able to transition into telework. And then those people who maybe were not able to go into telework. So there's many public health entities that you can't go into telework. You can't telework a vaccination to somebody. You can't telework a test to somebody. So I think being able to transition into those roles that weren't telework, but that were safely done and could have, these health departments be able to do these needs outside of the telework. And I think the last thing to think about, and I think this is more of a discussion question we can talk about at the end. I think this is something that, is interesting to me, is looking at, I think, and from a public health perspective, this is a giant event. And I think that there was a lot of burnout in public health, and in addition to other many different areas that worked on the pandemic. But I think the attrition of staff, the support that was needed for staff, and their kind of work-life balance resources. When the pandemic started, I was working, 12 hours a day, trying to track people down. I remember there was a young man who worked at a library reading children's books, and he was sick when he was doing that. And so there was just, a large contact tracing event that needed to happen. This was, I think it was March 15th when I talked to that case last year. And so it was just a lot of work went into the beginning of this to really see, how we could handle this pandemic. So looking at work-life balance and seeing how that affected attrition, seeing how that affected the support that was needed. What additional support did health departments bring in to, have this kind of mental health support for people working on this pandemic? So I think that's a good, a big place of evaluation that's needed to see what was in place and what did people have to bring, what did health departments have to bring in order to keep the really great public health workers we had at the time and continue to have. So I think then I'll pass it off to Carla. We're going to talk a little bit about some staffing capacity work we do with one of our clients to see, what our current staffing capacity is and how it shifts, with surges. As surges happen, how do we have to shift our staffing capacity, and how can a health department use a dashboard to look at their current staffing capacity and seeing where they need to bring people in, maybe externally, or bring people in within their department to kind of redeploy them. So I'll pass it back to Carla.
If you want to advance to the next slide. Awesome. So this is just a very basic, dashboard, but it has several things on it that I think are relevant to, this is specific for contact tracing. But as you can see up in the upper corner where it has the number of records worked each week. So you can see as the cases increased in time, if you look at the other side, there's the percentage of cases that we were able to contact within 24 hours. So as the cases increased, the number, the percentage definitely showed. So, when we had 20,000 cases a day or something ridiculous coming in, it's significantly harder, no matter how many people you have. If you could throw 1,000 people at it, you're still going to have difficulty reaching everybody just because it becomes so chaotic. But one of the things that we found as we got further along in the process was if we could do some sort of prediction ahead of the game, to be able to establish, okay, on average, we're able to do a certain number of cases is a reasonable number for one person to be able to manage. And we know how long on average it takes to ramp somebody up to be able to do that number of cases. So we were able to, ebb and flow and shift resources around depending upon what the needs were. So as testing increased and contact tracing kind of, was sunsetted, we were able to transition pretty quickly and pretty easily for most of our clients, because we were doing that sort of forward thinking and establishing who was going to be able to move between the different areas. And it really made a difference that we pretty early on also identified what metrics were vital, what was critical. Knowing how many calls a particular person, a contact tracer or a case investigator was going to be able to make on average, and how many people we think we're going to be able to actually contact in that period of time. Those are the kinds of metrics that you need. You can collect all of this data, but at the end of the day, you really just need a few really highly focused data points to be able to do that kind of forward thinking and forecasting, and still be able to meet the needs of your communities. But you have to make those decisions kind of early on, and you also have to make sure that you're paying attention to not just the overall numbers, but the specific community needs as well. So that are specific to whatever your local population actually has. All right, and Allison, I think this one is yours.
Yeah. So kind of the last area of evaluation looking at, and what we're going to talk about today, is kind of the future of public health and how COVID fits into that puzzle of public health. I think that I view it as, a new area added into a public health department. It's becoming less of a response and more of just an everyday task that people work on within, the health department. And so how prepared are health departments for that? So if we need to do quick transitions again in the future, because, potentially there's another surge or variants start to take control, and we're seeing that there is no resistance to this. And so we need to start looking at, back into telework. And so obviously those things are kind of hard to predict, but how prepared is the health department if that happens? What are some future quick transitions that are needed to put in place? Responding to public health trends that we're now seeing because of COVID. So we're seeing some heart event related outcomes increasing. People are waiting longer to go seek healthcare because they are not wanting to go into a hospital or whatever it may be. I'm doing my dissertation on adverse events related to cannabis use, and cannabis use is very much increasing across the nation. And so looking at, how are these increases in potential cannabis use, or I know tobacco use is also starting to slightly climb a little bit. So how can we respond to these new public health trends because of, I don't want to say because of COVID, but because there was a lot of focus on COVID, and how can we combine them together? And then also establishing the capacity and additional roles needed for responding to COVID within the health department. And kind of what Carla talked about, using predictive analytics to see, this is kind of what our future is going to be with COVID within the health department, and how can we kind of predict those? So those are more questions, and it's very hard to predict the future. If we could do it, I think we probably wouldn't have a COVID-19 pandemic. So I think that there's definitely a lot of questions and evaluation and things that we can try and work on, looking at gaps to see what are some gaps that we can fill as we move towards the future. So that's kind of the last area of evaluation that we're looking at. You can move to the next slide. This is just, so evaluating the response is kind of something we're looking at. AM Trace works with a lot of different local and state health departments, doing many different projects around COVID-19 pandemic, and looking at evaluating the future of COVID-19 with many of our clients. So you can connect with us in many different areas. And that concludes our piece, and I'll pass it back to one of the Elizabeths.
Thank you, Allison, and thank you both to Carla and Allison for this presentation. And I would now like to introduce Elizabeth Ruebush. She's the Director of Infectious Disease Outbreak Response and Recovery at the Association of State and Territorial Health Officials, or ASTO. Elizabeth manages and oversees ASTO's infectious disease outbreak response and recovery portfolio and serves as a technical lead on capacity building for COVID-19 case investigation and contact tracing. In this role, she oversees research around contact tracing, policy and program implementation, and supports public health response, staff training, and workforce development efforts. She received her Master's of Public Health from Johns Hopkins Bloomberg School of Public Health and a Bachelor's of Arts from Williams College. And so welcome, Elizabeth.
Thank you so much. And thank you for having me on this town hall today. For those of you who aren't familiar with ASTO, we're the Association of State and Territorial Health Officials, and we represent the Chief Health Commissioners in the states, territories, and District of Columbia. On the next slide, you can see our vision and mission statement. And that vision, that mission, these haven't changed, but the ways that we are working to meet that mission and vision have really changed over the past year, and the circumstances around it have changed as well. So on the next slide, my focus today will be on contact tracing. And as the topic for this town hall suggests, looking at our progress in this space with a bit of an evaluation lens. When we talk about evaluating contact tracing programs, we often think about key performance indicators related to length of time between contact elicitation and notification, or interview completion rates. And those measurements aren't important to assess, though for this conversation, I'd also like to look at evaluation from a broader perspective, not just assessing current performance, but also where we've been. So today I'll walk through a loose evaluation framework to help us look back and assess programmatic efforts over the past year, because I do think now is a good time to take stock of where we've been and where we're going, and to think through some of the questions on this screen related to our baseline. So what did contact tracing capacity look like prior to COVID-19, where we're going and how we forecasted our needs, which I think we heard some really interesting examples from the previous speakers. Tracking progress, including challenges, successes, and lessons learned, and determining what's next. So anticipating upcoming needs and aligning on the path forward. So first, in establishing a baseline, when we look at the workforce composition and trends prior to the pandemic, we know that state health workforce had decreased by almost 10% between 2012 and 2019. Specific to contact tracing, disease intervention specialists, or DIS, routinely carried out contact tracing activities in STI, HIV, and tuberculosis programs. And at the outset of the pandemic, we estimate that state and local health agencies employed about 2,200 DIS in these programs. The workforce was already under significant strain, with caseloads increasing, for example, in STI programs, and a limited number of personnel often responsible for case investigation and contact tracing in large geographic service areas. The CDC and national partners have for many years recognized the importance of this workforce, and in 2014 started exploring development of a national credentialing process for DIS. But I'll also point out that contact tracing has been a core fundamental function of public health for decades, since the 1930s really, and it's really more in our recent past that we've worked to professionalize the work of DIS, and I think that's evidenced by the efforts to credential this work function. So that's our baseline. And as we move into the next slide, projecting COVID-19 needs. To understand where we were going, we needed to assess our needs. So in the spring of 2020, public health leaders started calling for a dramatic increase in contact tracers to suppress outbreaks of COVID-19. And estimates for additions to the workforce ranged from 100,000 to 300,000 contact tracers needed to support the caseload of COVID-19. NACCHO developed a population-based benchmark estimating that 30 professionals per 100,000 population would be needed to support COVID-19 case investigation and contact tracing. And online estimators were also developed to project how many case investigators and contact tracers would be needed by jurisdiction based on caseload. And you can see an example of one of those estimators on the screen that was developed in collaboration with ASTO and NACCHO. On the next slide, we're moving into tracking progress. So as national experts were forecasting workforce needs, state and local health agencies were already moving into the difficult task of actually standing up and implementing these programs. So I'm presenting this as though it's a linear progression of events, but this really was all happening at the same time. So on the implementation side of things, we look to assess how this work was carried out. So from a practical and operational standpoint, what were the early strategies, models, and approaches that these programs were using? And what signals are we seeing with regards to key performance indicators? And for both of these questions, I'll direct you to the two resources that are featured on this slide. The first was co-authored with some of my colleagues at ASTO, and it characterizes challenges and successes associated with rapidly standing up new program structures and protocols, expanding and training the workforce, building public trust and participation in contact tracing, and assessing and adopting new technology options, amongst other factors. The second is an MMWR, where CDC looks at metrics related to caseloads, timeliness, and yield of case investigation and contact tracing amongst their ELC grantees. And they find, unsurprisingly, that there's a wide range of variation in capacity in these programs across the US. On the next slide, ASTO has also collected some snapshots from the field to assess a number of different dimensions of COVID-19 response. And in November of 2020, we conducted a short form survey to capture the state of play related to contact tracing. This survey went out as many states were experiencing a surge of cases in the fall. So information collected on program challenges was of particular interest to us. And at the time, 70% of responding jurisdictions reported that they didn't have enough staff to investigate all cases and trace all contacts. And when they were asked to indicate their top 5 challenges facing their contact tracing program, the most frequently selected items included expanding workforce due to disease resurgence, technology and data systems, public trust and acceptance, long-term and sustainable funding, and program protocols and workflows. On the next slide, we also invited respondents to share more information on the challenges they've been encountering, and themes from those responses are summarized on this slide. So under the first category, participants commented on the pressure that growing caseloads were placing on the workforce. They noted that workforce retention was a challenge due to the often temporary and virtual nature of the positions. And they also shared that communicating program guidance, procedures, and training requirements could be difficult given how large, highly distributed, and mobile their workforce was. There were comments around lack of public acceptance of contact tracing, pandemic fatigue, and populations becoming increasingly resistant to engaging in contact tracing efforts. And on the funding side, participants also expressed concerns about resources such as CARES funding expiring with no clear source to replace it. And I'll point out here that these data, again, are from November of 2020. So that was before some additional appropriations came through. So perceptions on this topic might have shifted. On the next slide, we also captured a snapshot of evolving needs. So we asked jurisdictions how they expect their contact tracing program needs to change as the pandemic progresses. And they wrote about strategies to streamline their efforts, including prioritizing cases and contacts and asking cases to notify their own contacts. Since then, we have seen more formal guidance come out from CDC that does reflect both of these approaches. Jurisdictions also reiterated ongoing workforce needs, including keeping training programs current, hiring more staff, and responding to high turnover and burnout. And participants also commented on future directions for improving program activities, including solutions for engaging the public, automating aspects of the workflow, and developing strategies to adapt and respond to rises and falls in case counts. I also included on this slide a quote from one of our respondents, which I think helps illustrate how dynamic and wide-ranging some of the short and longer term needs were at that point in November. And I anticipate that that's still the case now. We're actually fielding another assessment currently to kind of update some of these questions, see how any of these trends might have changed, and to collect a little bit more information on contact tracing programs. So to close out this loose evaluation framework, I think, again, it's important to assess what's next. And I've listed out on the screen here a few topic areas that ASTO is interested in exploring as we assess sustainability and define the path forward. So in terms of the expanded contact tracing workforce, what components of these gains are sustainable? To what extent are contact tracers looking at this work as an on-ramp into other positions in public health? And will health agencies have the funding and resources to cross-train these staff so they can pivot into other functions? From the technology and infrastructure side, ELC resources can be used to enhance and implement new technologies such as exposure notification apps, but we do know that further evaluation of these new technologies is also required. And we need to consider how contact tracing aligns with and is influenced by broader investments in public health data modernization. Contact tracing efforts have afforded health agencies the opportunity to build and expand relationships with traditional and non-traditional partners. And the next question here is, how do we sustain these partnerships? And finally, how do we emerge ready with flexible and adaptive systems that allow us to tweak our workflows and respond to new infectious diseases without overhauling our infrastructure, and rapidly scale up or down or redeploy workforce to areas of need? These are the questions that we don't have complete answers to, but they're on our radar. And I'm interested to hear how folks in the audience and on this panel are thinking about them as well. So with that, I'll close out. You have my contact information, and I'll turn it back over to Jody.
Thank you, Elizabeth, Carla, and Allison. Excellent presentations. Elizabeth, one question that came through while you were doing presentation is, did ASTO ask questions about communication challenges with different population groups, for example, non-English speakers or people with disabilities?
We didn't ask those questions in our rapid query. So the format of our rapid query instrument is, like I said, a short form survey, about 10 questions that's open for 10 days. And we try to reduce the burden as much as possible on our respondents so we can get a snapshot. So digging deeper into those sorts of questions, I think, are really important and are things that we're exploring, pursuing around in-depth interviews after we've collected contact information on folks from the first pass of rapid queries, or the first pass that we conducted.
Thank you. I think this is a question that I'll direct to Carla and Allison, and then Elizabeth, if you have anything else to add. How could the approach to evaluating gaps differ with the knowledge that COVID spreads more rapidly than what would typically be anticipated with pandemic influenza?
Actually, an interesting question. I think part of the advantages that we would have with something like the flu is that it happens every year, right? So we've got how many decades of data to work with there. The challenge that we had obviously with COVID was that this was the first time that we've really had both the technology to be able to track this data for the COVID responses, and also having it happen at the time when we had all of these things kind of come together at once. So I think when we're looking at the different gaps, there's obviously going to be certain things that are going to be like the same between any kind of public health response, I think. And those are the things that we would address the same way, no matter what the pandemic or the particular effect that we're trying to resolve. But I think that with something that is coming up next is going to be, how are we going to address the gaps for things when we have both COVID going on and then we have, for instance, the flu. Like, as these things kind of start meshing together, we're definitely going to have to look at some alternative ways to deal with the fallout from that, for sure. So in that regard, I think we absolutely are going to have to do some things a little bit outside the box from what we used to do, the way that we've used to handle things.
Allison, you have any other thoughts on that?
No, I think I agree with what Carla said, and I think there's some unique challenges that have come along with COVID that I think are unique to COVID, but not unique to COVID. I'm thinking like one of the things we saw really commonly in the COVID pandemic was household infection rates just really kind of we saw a lot of household transmission, and I don't think that's uncommon outside of COVID, but that was one of the drivers of a lot of transmission that was occurring, especially in populations that live in large households, and looking at populations that they have many people living in one house, and so we're seeing these high rates of transmission among the household, and then they commonly also have jobs outside of the household that they're having to report to, kind of essential worker positions. And so I think COVID highlighted a lot of gaps that we've kind of always seen, but it really just kind of bumped it up a lot of notches to see, these are some gaps and inequities that we're seeing within public health that were just really highlighted during the pandemic.
Great. Elizabeth, I'm leaving final comments to you if you have any. You can say you agree perfectly with Carla and Allison.
I do agree with them. And I think just one other comment to expand a little bit on that question is to look at contact tracing for other infectious diseases. And the reality is that this contact tracing was most commonly exercised for STIs, HIV, and tuberculosis. We have seen it used for measles in some instances, but this is the first time that we've really used it to pursue a respiratory infection where the chains of transmission look fundamentally different from the standard diseases that we usually contact trace. So as we think through, evaluation and where our gaps are in these programs, I think it's also important to keep that context in mind that walking into this, we didn't necessarily have an established benchmark for what success looked like. And this is a really challenging process to do for COVID-19. So that would be my last comment.
Maxine, who is kind of coordinating all of the call-ins and stuff, has a question from an attendee. So I'll let Maxine unmute them and put them through. Kathy, are you there? Kathy, it shows that you were still muted. Can you unmute your line? We're having a little bit of technical problems, so I'll let Maxine work with that and we will get back to Kathy. Several people are asking because they absolutely love your all slides. So they're asking, are these slides available? And for the attendees, and I'll put that out to you all. I'm assuming yes, but I don't want to say that without you all saying that.
We're happy to share them to make them more broadly available.
Okay. Allison,
Sure.
you're okay with that?
Absolutely, yeah.
Great, wonderful. Okay, and they can get them through your all's links or website. How can they get them?
Yeah, I think for folks that captured our contact information, they can reach out. Otherwise, we'll coordinate with NACCHO staff to see about having them uploaded.
Okay.
Yeah, same.
Great. It appears that Kathy did not have a question and she's not sure why her hand was raised. So we'll, I also noticed that my face gets very glowing and it's not from excitement. I have a window that faces south and the curtains and the sun is in and out of the clouds and the curtains are not blocking the sun. So please excuse that gradient glow of excitement from time to time. have another question for ASTHO. Did ASTHO ask any questions about local jurisdictions' ability to keep their own staff safe while out in the field? And that's one gap that this attendee had identified in California, the lack of a comprehensive safety program for emergency activated staff deployed in the field, like fit testing, health surveillance, monitoring, et cetera. So Elizabeth, that's yours.
Yeah, I saw that comment come through and thought that was such an important point. We didn't ask questions along those lines in our first survey. We were trying to characterize the models that contact tracing programs were taking, whether or not they were performing care coordination services, where they felt they were in terms of their staff numbers. So we weren't unfortunately able to get into that level of nuance, but I think it's an important question and speaks to potentially, how quickly these programs were stood up. And that involved a lot of new protocols being developed and evolving as the science changed as well. So my sense is that those sorts of efforts have improved over time, but I really do appreciate the question, because I do imagine that this was a challenge for many jurisdictions.
One of the participants also noted, Elizabeth, that they were really encouraged to hear that you are interested in looking at public information and language ADA access. They said that this seems to be a capability that is overlooked in national conversations until it's needed and in high demand for response. So it's a good, that's a really thrilled that that's being looked at. Okay, let me ask another question here. As more people are getting vaccinated, hopefully new cases are going to be declining. So can you talk about how case investigations and contact tracing priorities and approaches might change over time? For example, will there be a greater focus on source investigation or integrating contact tracing with rapid COVID testing or vaccination? What implications are there for changes in training approaches or refinements for data collection systems? That's a lengthy question, but I'll let Allison, and Carla take a stab at that one.
Can you repeat the first part of the question?
Sure.
Kind of how do we see it
Sure,
changing?
this is a lengthy question. As more people get vaccinated, hopefully new cases will decline. Can you talk about how case investigations and contact tracing priorities and approaches might change over time? For example, will there be a greater focus on source investigation or integrating contact tracing with rapid COVID testing or vaccination? And then what implications are there for changes in training approaches or refinements for data collection systems?
Mm-hmm. Yeah, I think that's a really great question, because I think that it kind of harkens back to the beginning of the pandemic, where we were really trying to do containment and seeing where we were seeing cases, getting them isolated so that they weren't, that we were mitigating the spread of the illness. And so I think it'll kind of cycle back to that, where we try to, with case investigation and contact tracing, kind of isolate and quarantine so we can contain the illness. And so I think that kind of brings in the vaccination and testing. I think that is where rapid testing and vaccination can occur, because if we identify the contacts, get them tested, get them vaccinated if they haven't been vaccinated, then we can help prevent further spread while they're quarantining. And so I think as far as implications with training and kind of reorienting what we're doing in contact tracing, it is more of like a linkage of services. So we're doing contact tracing, we're reaching out to people to say you were potentially exposed to COVID, we need to get you tested. And this is in like already having the testing appointment set up, already having the vaccination appointment set up. So having all of these services that are done during the COVID pandemic of contact tracing, testing, and vaccination, kind of linking them all together, which they are now, but making it in an even more linked kind of response. And so that I think one of the things that could potentially be done is, I think a lot of communities are doing mobile testing and mobile vaccination. If you can bring the testing and the vaccination to where people are, then they don't have to seek out the testing and the vaccination. So I think that's where we were trying to do in the beginning, but then it just, the numbers really kind of got away from us, and it's not a viable option to do something like that with such a large scale and with such a large number. So I think that's what I would, foresee things moving towards, where all of these things are combined into one. And so that we can not just say, you were exposed to COVID, you should go get a test. Here's some places where you can get a test, but actually linking them and getting them set up with these testing, with these vaccinations, and getting that kind of all put into one. That's why I think that's probably the future. And then the implications of training would be, I think moving more towards kind of what Elizabeth presented on in the disease intervention specialists. I think they can become a more comprehensive role in terms of doing all of those together, doing the tracing and the testing and the vaccination. So I think, it kind of maybe becomes a new role in the public health realm, a COVID-19 disease intervention specialist, and they do all three. They can do all three of the services in one role. So that's what I would think and see the future going towards.
Carla, you are the data guru for AM Trace. So I was wondering what your thoughts on what implications are there for changes in training approaches or refinements in terms of data collection systems?
Well, I don't know so much about the training piece of it, but what I can say is that you hit the nail on the head with the way that the responses are trending now. At the beginning of the pandemic, everybody was in sort of let's just make it work mode. So we had, obviously vaccination wasn't a concern. It was a concern, but it wasn't available. So contact tracing became like everybody put all of their resources into contact tracing. And then testing became, the secondary piece. And so it was very siloed. We had, a certain group of people that were working on contact tracing and a certain group of people that were working on testing, and they weren't necessarily working in tandem. And there was also a certain component of, like, particularly for the data, a lot of our clients were doing things in just a week to week, sometimes even a day-to-day basis. They were collecting data and they were looking at what happened last week, but they weren't looking at what happened over time, over the last 12 weeks or, whatever the time frame was. And so, as we got more and more cases, it became more and more difficult to kind of make any kind of headway into anything because you were just trying to survive. So now that we've kind of gotten over that, hopefully the biggest hump, now we're at the point where we're able to start doing some evaluations to look at things in a big picture, holistic kind of way, which is, I think, really going to drive the way that we handle it going forward. We were able to combine the resources now between the testing groups and the contact tracing groups and look at the data as a whole and then integrate into the vaccine programs. So I think that that's definitely going to be hopefully something that all of us have learned, that we can't just hit it in individual little silos. We have to kind of try to look at it from a big picture perspective. And I think that's probably where the training is going to go. Like Allison said, we're going to start having people that are, doing all of those things in one role, as opposed to trying to just separate it out into three different ones.
Excellent. Elizabeth, any final thoughts on that multitudinous question?
Sure. Yeah. So I would add that I would expect contact tracing to potentially become more effective as case numbers go down. When you think of the epi curve or the outbreak peak, contact tracing is traditionally used in the suppression and containment phases. So on either side of that peak to run down, the final number of cases or clusters that might be occurring. So I think contact tracing will still play a really important role as more people are vaccinated and we see a smaller number of cases. And in thinking through where the workforce goes from here, that's what we're really interested in as well. We're asking some questions around how folks are integrating vaccine education outreach work into contact tracer workflows, or any current or planned training efforts to cross-train contact tracers. A lot of the skills and characteristics that make a good contact tracer is that they know the community that they're working with well and are good at building rapport and communicating messages. And a lot of that does overlap with what we traditionally see in community health workers and outreach workers. So these folks will be trained and skilled in a number of competencies that we would value in a range of different areas in the public health workforce. So we're interested in seeing how they pivot and perhaps move into other disease areas or other spaces of the health department.
Great, thank you all. Some more questions, and again, we have a few more minutes and we can go over about 15. It's almost about 1:15, but we can go over an extra additional few minutes. So if you've got any further questions, please send them in. One question that is on my mind is that AM Trace and many other organizations provide expertise and tools to supplement local health department staffing and systems for COVID-19. What are the advantages and disadvantages of public-private partnerships like this? And how can these partnerships be sustained for the long term? And Elizabeth, since you're on, I'll start with you and then we'll go to Carla and her colleague, Allison.
Well, I'll be really interested in hearing from Carla and Allison about their experience as well, but I do think this response has highlighted how important those partnerships are. And it's not always a space where health agencies have a lot of experience. We've seen some impressive partnerships in the technology space as contact tracing programs explore new technology options to automate and facilitate some of their processes. And I think it's just a good example of the skill set, the knowledge and expertise that can be brought to bear when we engage a cross-sector group of collaborators. I think in building those new partnerships, there's some level setting to be made. The public and private sector generally are driven by different goals. So aligning on what those objectives are and learning how to speak the same language to a certain extent is important. But my hope would be that these partnerships are maintained because as we look at upcoming investments around data modernization, I think health departments really will need to rely on building and expanding partnerships with the private sector to ensure that they're taking advantage of all the modern options that are available to them while assuring privacy and safety and all the other components that health departments really are looking after as well.
Carla, Allison, both Elizabeth and I are really wanting to hear from you about this public-private partnership concept.
Well, I can say probably the thing that has been the most obvious, I think, in this whole the partnership world is just the simple thing that we've learned from all of the different kinds of clients that we work with, that we can then bring that experience to play. A lot of conversations start with, well, we learned when we did this with so-and-so, how to use all of the different things that we have managed to pick up over the different organizations. Plus, we also see how different everybody is handling things, right? Everybody has their own way of organizationally dealing with the pandemic and all of the things the components that go with it. And then I think the other thing really just goes back to that siloed effect like I was talking about before, where because we as AM Trace, for instance, work with the vaccine program at your organization and the testing program and the contact tracing program, it really has allowed us to be able to kind of give that big picture at maybe an earlier stage than they would have otherwise had time to address those kinds of issues. So.
Great. Allison, any other thoughts?
Yeah, I think one of the advantages of the public-private partnership especially with AM Trace is that we have the ability to rapidly implement whatever it is that is needed by the client or the health department. And so they kind of come to us and they say, you know, this is what we need from you as AM Trace, and we can rapidly implement that. So way back in the summer when we started helping a client with contact tracing, we were able to implement that, you know, right away. And we have models built out within the company to, you know, rapidly deploy whatever it is needed. And so we do other projects outside of contact tracing. We work on some canvassing projects in a large metropolitan area, very large metropolitan area. And so we can do on the ground work, we do evaluation work. So I think kind of what Carla said, we have expertise from working with all of these other entities and health departments. And I think that's one of the advantages of a private-public partnership of, you know, this agency has worked with other health departments and this is what they've seen and this is what they've experienced, and they can kind of pass the knowledge along so that it allows other public health departments to kind of rise to the level that they need to be able to work with, you know, whatever they're doing with COVID or outside of COVID. And so we can be a facilitator of passing along the knowledge between health departments and in a private-public partnership. So yeah, I think that's the only kind of thing I would add.
Great. I'm going to try one more question. I think we have time for another question. Even before COVID, our contact tracing workforce was insufficient to meet the demands of our HIV, STI, TB, and other infectious disease programs. And then those staff were redirected to COVID. And I know particularly Elizabeth and you all spoke about that. Now we have over 60,000 contact tracers. I think that's the number, it may be more, across the US recruited to meet COVID demands. How can we best sustain this workforce to replenish our existing STI and HIV programs, continue to work on COVID and other health department programs, and to ensure we are ready for the next emerging infectious disease? And Allison, you're the face on the camera right now, so we'll go to you first. Put you on the spot.
So I think the base of the question is we have this really robust workforce of contact tracers, and we used to not have a robust workforce of contact tracers out, you know, before COVID started. So how can we keep these people and use them elsewhere? That's kind of what I'm getting from the question.
Yes.
Correct? Okay.
Yes. Well, and yeah, how can we sustain the workforce and continue everything else that we're expected to do? Yeah.
Right. Yeah. And I think that I saw somebody put something in the chat and I just saw the word funding. And I think that is kind of the crux of it all is, you know, we have the enormous amount of funding right now for the COVID pandemic. And so we're able to fund these 60,000 contact tracers. And when some of that funding starts to dwindle away for COVID, how can we keep these people on to work on, you know, the tracing that's needed outside of COVID, like Elizabeth talked about with TB and STIs and other diseases? You know, that's the biggest piece of, you know, those infectious diseases that helps containment and mitigate the spread of those illnesses. And so, you know, I think it's the unsolvable question of funding. I think funding is always everybody's kind of, you know, when, you know, stitch in your side that you can never get rid of. And so I think, yeah, I mean, it's a tough question. I think that, you know, with public-private partnerships, you can kind of sustain some of that so that, you know, there's this workforce of contact tracers, and you can kind of work with these public-private partnerships to continue that work elsewhere outside of COVID. But I think that, you know, I think it's a tough question for me. Yeah, I mean, I think public-private partnerships is one of the answers, but I'm sure there's many other answers to it.
Carla, any thoughts on that?
Honestly, I think I like to think of things as a positive. I know that necessarily just because of funding, we're not going to be able to put all 60,000 of those people back into contact tracing for other avenues. However, and I know 60,000 is a small number compared to the 400 million that are in this country, but I think that it is important to remember that that is a significantly larger number than we had before of people that now truly have a even better understanding, I think, of why public health is important. And that's always been a challenge. I know Allison and I had lots of conversations about that before we started this project, because it's always sort of been on the back burner. It's never really necessarily been in the front of people's minds when they think about a necessary thing that we need as a community. And I feel like if nothing else, this has, for as many people as we possibly could have influenced this way, I think that we've been able to at least make it in the forefront, and hopefully we can just keep that momentum going with education and, you know, activities and things that we can use to hopefully keep that momentum going while we've got it.
Elizabeth, I want to I said this was going to be the final question, but I have one quick question about advocacy. You know, public-private partnerships often require funding to maintain. And we know that Carla is not a multimillionaire. So what are the plans for advocacy to secure funding on technology modernization over the long haul? Kind of picking your brain on that question, because funding for technology modernization is quite critical here.
Mm-hmm. Well, you know, throughout the pandemic response, our government affairs arm at ASTO has really been active in collecting from our members their characterization of the resource needs and sharing that with various levels of government, policymakers, decision makers. And I think some of the themes there is that we're advocating for sustained long-term funding. This can't be just an influx of resources that happens once or twice over the course of a year. It needs to be sustained funding to improve some of the you know, preparedness and other programs that have slowly eroded over the years due to a lack of funding. And in those sustainable funding structures, we're also looking for flexibility. So not overly prescriptive in terms of, you know, the exact actions that need to be taken, because I think it's within that flexibility that jurisdictions will be able to pursue partnerships with non-traditional partners. And if they have a period of time that's long enough to spend those resources, so that's kind of another space that we're looking at, is just not, you know, 1 year long funding, but something that lasts over a period of time that gives them the space to, you know, scan the space, the landscape of partnerships that they might need to develop. And then also it gives them time to grow that and really bring it to fruition over time.
Thank you. It's getting close to time to close, so I'm just gonna take a moment to really thank Carla and Allison and AM Trace for funding and supporting this town hall. Also want to thank Elizabeth, all of you all, for helping us take a closer look at constructing a rigorous evaluation and strategy, not just for our COVID, but for some of our other public health preparedness programs that will increase our capabilities and make us more resilient and prepared so that we can emerge ready to address any public health challenges that we as a nation may face. Also want to take a minute to thank the people backstage, Maxine, Elizabeth, all of the production people, all of the people that have made this possible. I don't know how many of you all have done this before, but it takes tons of effort. And those are the people that really deserve a big applause. We just sit here and try to look pretty, but they're the ones doing all the work. So I really appreciate you all, the audience, and thank you for joining this town hall. Have a good afternoon.